Hello, very good afternoon to everybody, and welcome to this public forum organized by the Department of Urology, Singapore General Hospital. So today's topic is on urological cancer. On behalf of the department, my name is John Yuan. I welcome everybody. And as you can see, can I have a next slide? I want you to see that the whole department welcome you to this forum. As you can see, we are quite a big department, and you might be familiar with the familiar faces among our senior doctors. Today, I want to introduce you some of our younger doctors who are all very well trained, who all have international credential and international standing. And they'll be talking to you today. And if you come and you see any one of us, you're in good hands. Today, we have Dr. Tay Jack and Dr. Kenneth Chen, who will be talking to you about how to diagnose and treatment of kidney cancer. Next one. Next slide. So as the first and the oldest department in Singapore, we are actually specialized in all aspects of urological services, from kidney stones to transplant, men's health, urinary incontinence, and to cancer services. We cover them all. In fact, we are quite well established in our cancer service. We have a team of about 5 cancer service specialists. And today, we talk about kidney cancer in particular. Next slide. So we're going to have a panel of speakers. As I mentioned, Dr. Kenneth Chan and Dr. Tay Jack will talk about the diagnosis and the treatment of kidney cancer from the surgery perspective. And Dr. Apua, who is from our Interventions Radiology department, who is going to talk about how to manage kidney cancer from the Interventions Radiology perspective. And what is very unique for today's forum is we are going to have a member of the public, Ms. Limbert Lim, who is coming on board to share with us her experience in her treatment journey in the treatment of kidney cancer. I think this is a very important insight, not only for the member of the public and also for the doctors to know what is the patient side of the story. So we are really, really appreciative of Ms. Linda's effort and time to come to today's forum and talk about her experience. Next one. So today's activity is actually a series, a part of a series of activities in our 35th anniversary for the SGH Department of Urology. And we are going to have another public forum on urological diseases and on the 11th of November. And the date is quite easy to remember. It's a super single day, 11th of November, and I hope to see you there again. Next one. So last but not least, I would like to mention that as a department, we are being recognized as one of the best in the world, operating in one of the best hospitals in the world, Singapore General Hospital. And this wouldn't be possible without the support and trust of our patients and the member of the public. So for that, we hope to continue to receive your support and your trust, and we promise to do our best. So for this public forum, I would encourage you to post as many questions as you can by posting it online. And I would like to introduce the next speaker, who is Clinical Assistant Professor Dr. Kenneth Chen, who is one of our cancer specialists actually in our department, and who has just returned from a very renowned fellowship from a very renowned hospital in Australia, Peter MacCallum Cancer Centre. And his special interest is on keyhole surgery for kidney, prostate, and bladder cancer. And his topic today is blood in the urine cancer. Kenneth, over to you now.
Right. Thank you. Thanks, John, for the very kind introduction. I hope everyone can hear me well. A very good afternoon to one and all. It's very heartening to see such strong interest and the gathering of such a great crowd on a Saturday afternoon to listen to this topic. So without further ado, I'm just going to quickly launch into my topic of the series of lectures. Blood in the urine, when is it significant? So this is the outline of my talk. Firstly, I'll be talking about the difference between invisible versus visible blood in the urine, and when should we all be worried. And next, we'll move on to what are some of the causes of this blood in the urine, where is it coming from? And lastly, I'll end off with what are some of the investigations that one with blood in the urine will need to do. So firstly, broadly speaking, there are just two categories of blood in the urine. Firstly is the invisible one, where, the most common scenario would be, when one goes for pre-employment check or yearly check at the polyclinic. As part of that checkup, the urine has to be submitted for assessment, and the doctor comes back and tells you that there's some traces of blood in the urine. But your urine actually looks perfectly fine. It's clear, it's got the usual yellow tinge, but you are shocked to hear about blood in the urine. So that's what we call invisible blood in the urine. And these are very, very minute amounts of blood that is only seen under a microscope. So that's called microscopic or invisible blood in the urine. On the other hand, we have visible blood in the urine. So that's visible to the naked eye, and that's the most common cause for panic in a lot of our patients. You wake up, start seeing blood in the urine. This is also known as macroscopic. So there's a lot of difference between these two, which we'll talk a bit more in just a while. But firstly, let's start off with microscopic blood in the urine. What constitutes microscopic blood? So there are various definitions out there, but generally speaking, we're talking about more than 3 to 5 red blood cells under a high power microscopic view in a urinary sample that you've submitted. And some of these definitions actually do require at least 2 samples, blood in the urine, to be confirmed on at least 2 samples to qualify for further, evaluation. And we'll talk a bit more about why this requirement to have 2 samples. But maybe I'll just debunk a common myth first. My GP uses urine distich. Does it count? So urine distich is a very good bedside adjunct to the physician's assessment of a patient. But in summary, it's actually not accurate enough to tell us the full picture. So specifically, it cannot distinguish between various causes that may masquerade as blood in the urine. So when your urine distich comes back positive for blood, it may not be truly blood, and it may be other products that's found in the urine. So suffice to say, if the urine distich is positive, what it means is that you should just follow up with a formal urine examination, a microscopic examination. So that's called UFIM. So this is a more specific, more sensitive kind of test compared to the dipstick. But should you be worried? So let's say you've had 2 samples submitted to the GP or your polyclinic doctor, and then he comes back to tell you that, hey, there's still a lot of red blood cells seen. So should you be worried? Well, the data shows that actually more often than not, you're not going to find anything significant. Cancers can be found, but in a very small minority, up to about 10%. And most of these cancers are actually incidental, probably very early stage cancers. They're not giving you any symptoms. There are a lot of other causes explaining why you have blood in the urine, and we'll talk a lot more about these later. But I think I just want to start this session by maybe reassuring a lot of you out there that there are more benign causes than there are cancers found when we investigate people with traces of blood in the urine. A good place to start off is to ask ourselves, do you have urinary symptoms? So the most commonly detected cause would be probably a suspected UTI, especially if you have urinary frequency, pain when you pass urine, these should all raise suspicion of an infection. And if it's truly an infection, you should just treat it with a course of antibiotics and repeat the urine test after. And that should give more clarity. Now, of course, if there's still traces of blood found after and it's persistent, of course, you should proceed with further evaluation. Now, if you do not have symptoms and it's just incidental, this could be what we call transient. So that's why we recommend that at least 2 positive samples of urine should be required before you get a formal referral to the urologist or the tertiary center for further checkups. Now, why? Because there are many reasons why we can have occasional blood in the urine found. And some of these causes are listed here, as you can see, especially, after vigorous physical exercise, if you check your urine, you're going to find some traces of blood in the urine. And after other activities, such as sexual intercourse, or even from a doctor's examination of the prostate for men. So minor things like that can cause traces of blood in the urine. So it's very sensitive, but not very specific test. And of course, for females, we always want to clarify that it's not contamination from the menstrual period. Another common myth that I really want to debunk is that, doctor, I'm on some form of antiplatelets for my heart. The common drugs that we know of are like aspirin, Plavix. Is that why I'm bleeding? Should I still go for further investigation? Now, the answer is being on these medications do predispose you to bleeding, but it should not deter you from a proper full evaluation. So meaning to say, we must not dismiss it purely because of medications that you're taking. If it's been found it's persistent, you should still undergo a proper evaluation according to the guidelines, as you can see here. Okay, so we've talked a lot about what constitutes blood in the urine. When should we be concerned? So now comes the more interesting part. So where exactly is this blood coming from? What are some of the causes that we're talking about? Again, I would like to make it simple for everyone. I will broadly categorize it into 2 categories. So if you think in a very simplistic manner, the blood that is found in the urine sample could either be leaking into the urine from the kidneys, or you could really be bleeding into the urinary tract. So let's talk about this leaking. I think maybe some of you are scratching your head a bit. What do you mean by leaking? So let's start off with the function of the kidney. So our kidneys are filtration organs. So we know that the kidney filters our blood, and in the process of doing so, it helps to expel metabolic waste and toxins from the body. If I can bring your attention to the top right figure over here, this is anatomy of our kidney, and you can see at a very microscopic level, there's this thing called the glomerulus. So this is the smallest and the most microscopic unit of the entire filtration system. So it's at this particular spot where blood actually flows through, and the toxic waste are extracted and secreted as urine. Now, when the kidney suffers certain insults, infection, inflammation, sometimes even certain rheumatological conditions and things like that, when the kidney is diseased, so the filter may be affected, and thus red blood cells may actually get into the urine on top of all the metabolic waste. So this is what I mean by red blood cells leaking into the urine. So during the investigative process, certain signs may suggest that this could be the underlying cause. For example, if we find excessive protein in your urine, if we find certain particles in the urine under the microscope called casts, and also under the microscope, we're able to see the morphology, the shape of the red blood cells that we are detecting. Are they looking like normal red blood cells, or do they have a different shape and form? So all these things actually can suggest this as a possible underlying cause. And if this is so, then usually the urologist ourselves or your GP will make a referral to the nephrologist. So the nephrologists are the specialists in charge of the internal health of the kidney. Now moving on now to bleeding. So bleeding is of course, the other major cause of why blood is found in the urine. And if you look at the anatomy of our urinary tract, it's actually a long way before the urine actually gets expelled. So urine is first formed in the kidney and it travels down two tiny tubes called the ureters before finally coming into a reservoir called our bladder. And for men, we have the prostate. And lastly, the last part of this urinary tract is called the urethra before it gets expelled out of our body as urine. So blood can actually come from any part of this entire journey. So let's talk about some of the common causes why you can have this blood in the urine. So kidney cyst. So this is a very, very common condition and diagnosis that we find in a lot of our patients. Essentially, it's a fluid-filled bubble. I always convey in a very layman term, a fluid-filled bubble that's found in the kidney. And you can see this is how it looks like on the ultrasound on the left, and how it looks like in a real life specimen of the kidney. Okay. Now, generally speaking, these are benign, entirely benign. They don't pose immediate threat to your kidney or your health most of the time. Another common cause is inflammation. Now, inflammation is just a reaction to very often infection, things like that. So infection of any part of that urinary system we talked about. For men, it can happen in the prostate, and this is called prostatitis. It can also happen in the bladder, as you can see on the scope pictures of the bladder. Very angry looking, very red kind of appearance of the bladder. These are typical pictures of inflammation of the bladder. So when there's inflammation, it's very likely that some of these red blood cells can bleed into the urine. And of course, we cannot miss out stones. Stones is a very big urological condition impacting a huge part of the population. And again, stones, as we've mentioned, can occur in any part of this urinary tract, in the kidneys, in the ureter, and the bladder. And it's not very uncommon that during our evaluation of a patient with blood in the urine, we uncover the diagnosis of stones. So not all stones are actually symptomatic and give pain. So sometimes you may be harboring a stone in your urinary tract, and that is the culprit for that blood in the urine. And of course, cancer, the word that weighs down very heavily in a lot of our hearts and minds. Nobody wants to hear the term cancer, right? But truth is, yes, we do pick up a fair amount of cancers incidentally during the investigation for blood in the urine. And again, the cancer can form in any part of that urinary tract. We've got kidney cancer, which we'll be talking in more details today. We've got bladder cancer, and men prostate cancer is a very big problem, not just in Singapore, but globally as well. But perhaps at this juncture, I just want to highlight and make a statement that, if you have blood in the urine, especially visible blood in the urine, it is more like, and if it's due to cancer, it is more likely to be bladder cancer than any of the other cancers, okay? So this is just statistics, and this is how the cancer presents. And lastly, I just want to bring in this condition of pelvic radiation. I think for those who have had it, you would know. So some of us may have had radiation therapy to the pelvis for other cancers, for example, rectal cancer or gynecological cancers. And what radiation does is it actually causes a lot of collateral damage. So bladder, is being a pelvic organ, will come into the radiation field and suffers as an innocent bystander. So this picture on the left here shows a typical picture of how the inside of a bladder looks like after radiation. And you can see all this blood vessels. There will be a lot of blood vessels, very friable blood vessels that can bleed. So it is very, very common, and I would say almost consistently we'll see blood in the urine, microscopic blood in the urine for anyone who's had radiation therapy before. Yes, so we've talked a lot about microscopic hematuria or blood in the urine. Just a quick slide on visible blood in the urine. So by the very fact that it is visible, it just means that, you know, there's a lot more of that red blood cells that are present in the urine. So this always signifies that something is underlying, there's a significant underlying cause. And we almost can identify a cause in more than a third of patients. And we're particularly sensitive to patients who present with painless visible blood in urine. Especially men, elderly, and smokers, we really have to be cautious and to rule out bladder cancer. So bottom line is anyone with blood in the urine, visible blood in the urine, always warrants a thorough and detailed medical examination by the urologist. I've come to the last part of my talk. What investigations does one need? So after being referred to the urologist, we will first see you in the clinic. We'll take a detailed history. We'll find out, you know, from the history, what are some of the risk factors you have? What could it be if you have previous history of stones or cancers and things like that? We'll do a bedside ultrasound to have a gross picture and evaluation of your urinary tract. But definitely a thorough examination involves or entails proper urine tests. For men, a blood test to check on the PSA, which is a marker of the prostate health. And of course, definitely some form of imaging. And this can come in the form of an ultrasound or a CT scan, depending on your doctor. Now, for all cases of visible blood in the urine, we'll almost always follow up with a endoscopic evaluation of the bladder, which doesn't take too long. It only takes about 1 to 2 minutes. It's done in the clinic setting, and it allows us to visualize the internal lining of the bladder and to see if there's any possibility of bladder cancer or any of the other causes. So I think I'd like to end off here with some take-home messages. So it is important at the very first instance to rule out benign causes and contaminated samples, and to confirm with 2 samples actually. Now, after that is done, if you still have persistent blood in the urine, most of the time, no underlying cause is found, even after going through a thorough examination, so not to worry. But it's a different story when it comes to visible blood in the urine. I think it's very important to go through a thorough and early examination or assessment by the urologist. So with that, I thank you for your time. And I would like to bring on the next speaker. So the next speaker is Dr. Apurva, a close friend and colleague of mine. He's a senior consultant in the Department of Vascular and Interventional Radiology over at Singapore General Hospital. He's got subspecialty interests in minimally invasive interventions for cancers. So without further ado, I'll pass the time over to Apurva.
Hello. Good afternoon, everyone. Thanks for joining me. Thanks for joining us this afternoon. I hope you can see my slides okay and hear me well. So my name is Dr. Apu. I'm an interventional radiologist in SGH. I'm honored to be speaking to you today about a topic which is one of my main areas of interest. Dr. Chen talked about, the many different broad causes of blood in the urine. For this one, I'm really going to talk only about kidney tumors, specifically kidney cancers, which, as he shared with you, is really a very small part of the overall cause for blood in the urine. But it's something that we do increasingly, and it's an important topic, I think, for everyone to be a little bit familiar with. This is an outline of my presentation. I'll give you a little bit of background about the kidney and kidney tumors, which would be relevant for ablation specifically. We will go over the different types of commonly used ablation, the pros and cons of ablation in general, and finally, we'll end off with one challenging case example. So as Dr. Chen shared with you, kidneys are paired structures at the back of the body. They are essential organs. They are bean-shaped, and you can see why the yunto gets its name. It has this reddish appearance. It's about 10 to 12 centimeters in length, and the main function of the kidney is to produce urine, among many other important functions. The kidney has a central hilum, which is where the blood enters and leaves the kidney, and also where the urine leaves the kidney to go to the bladder. This hilum is a very important structure when we talk about whether something can be ablated safely or not. And I'll show you what I mean. The hilum is where the renal artery, which is where the blood goes from the heart into the kidney, goes in, and the blood makes a U-turn at the edge of the kidney. And as it does so, it spits out the toxins and waste products into the collecting system, which is here. Eventually, that forms a ureter and it brings the urine down into the bladder. The kidney is a small and complex organ, but a very high rate of blood flow enters the kidney because it needs to clean the whole body's blood, and about 1 liter of blood goes into the kidney every minute. This is a picture taken of an actual human kidney in cross-section. The little black dots are the glomeruli, which, as Dr. Chen mentioned, are the urine-making cells. God gave us only a few of these, and we have to live with them throughout the whole life, about 1 to 2 million per kidney. Naturally, as we age, these cells tend to decline just over our lifespan. And some diseases like diabetes and high blood pressure, and even some medications can cause these to decline. And that's why it's really important to protect our nephrons because they're going to last us our whole life. This is a picture of a kidney tumor taken from a journal. You can see that it is a very ugly looking growth that is at the kidney. Is clearly different from the surrounding pink, nice, healthy kidney. It has a slightly yellowish appearance because it typically has a lot of fat in it. And these red structures are the blood vessels. The kidney tumor has a lot of blood going into it. And this is a blood vessel that's flowing into the tumor. This is also how kidney tumors tend to spread. They go through the bloodstream and they can spread into the heart and the lungs and bones and so on. Surrounding this kidney tumor, there are all of these normal, healthy kidney urine producing cells. So when we treat this kidney tumor, there will naturally be a little bit of damage or collateral damage to those healthy cells. And nephron loss is something that is a very important part of how we do our treatment planning. I'm going to show you the CT scan of a patient who was found to have a kidney tumor by chance or incidentally. The patient actually did not have any blood in the urine. This tumor was picked up because he had a CT scan done for other reasons. And as we were looking through all the different organs on the CT scan, we found this growth that is in the upper part of the kidney. Remember, I said the kidneys are at the back of the body. So this is the spine of the patient. This is the hilum where the urine is coming out here. This is the tumor that is located in the cortex in the upper part of the kidney. On cross-section, this white stuff here is the contrast or the dye that is given that's being excreted out of the kidney and going down into the bladder over here. And the growth is in the upper part of the kidney right next to the liver. So this incidental finding is actually increasing. More and more of these tumors are being found incidentally. We use a classification system to help us decide on the type of treatment to be done. And for ablation particularly, we only restrict ourselves to the type 1A, which is the earliest type of kidney tumor. It is also actually the most common type of kidney tumor that is detected nowadays. They are fortunately detected at an early stage, and 1A is when they are less than 4 centimeters. Okay, so let's move on to ablation. There are 4 commonly used types of ablation. There are 2 of them are heat-based systems called radiofrequency ablation and microwave ablation. The third one is my preferred method that's called cryoablation using extreme cold. The fourth method is not commonly used for the kidney, and I will not be expanding on that. The term ablation means that the tissue or abnormal cells are destroyed inside the body. They are not taken out because that is surgery. They're left inside the body, but the cells are dead. Over time, the body gets rid of this destroyed tissue, but there's always a scar that can be seen. Even years later, if you do a scan, you'll see the ablation zone as an area of scarring. Cryoablation refers to using extreme cold. Now, extreme cold or cold therapy itself is not new. We've known about this. People have written about it even 5,000 years ago. But what I'm talking about is using extreme cold to kill tumors. It is quite different from science fiction. You know, Captain America went into the ice for 60 years, came out unharmed. That's not what we're going to do. We're going to actually kill cells. So this is how it's done. This is a cryoablation needle. It generates an ice ball. There are different types and sizes of this ablation zone, depending on the type of needle that we choose. We can combine these to give us a slightly bigger zone as well. The biggest advantage is that it is an area that is visible on scanning. So we can see exactly where we are trying to ablate. This is a model under a CT scan, but I'll show you some real pictures. This is how the ablation is done in our room. We have a specialized room with quite advanced imaging equipment. This is a patient who is lying face down because kidneys are at the back. So this is the spine or the back of the patient. The patient is under general anesthesia to make sure that he's comfortable. There's a sterile, completely sterile field preparation and under constant monitoring. In terms of imaging guidance, we use CT scans. This is really important to see the kidney and its relation to surrounding important structures. We use ultrasound, which helps us place the needle safely because near the kidney, there are very important structures that we want to avoid. And then here we can see a wire that's going into the cryoablation generator. This is an animation of the actual cryoablation procedure. There's no sound, but it shows a model of the kidney that's located. Needles are placed into the tumor. Depending on the size, you may have to use more than one. In this case, 3. An ice ball is generated. And we use freeze, thaw, freeze cycle because the rapid freezing and thawing is the one that helps to kill cells. We'll skip over this in the interest of time. So we freeze, we thaw, and we freeze again, and we take the needles out. This is an on-table example of how that looks like. This is a porcine or pig kidney where a needle for cryoablation is inserted into the kidney. And you can see the ice ball forming over here. This is the ice that's forming within the kidney. Now, the big advantage here, this is how it looks. Presuming the tumor is here, a bit of the normal kidney would be damaged as well. But after the ablation, actually the area looks very normal. It does not seem to have a lot of damage done to it. And one of the big advantages of cryoablation is that it preserves the architecture. It kills the cells, but the underlying scaffolding, the collagen fibers that are holding up the kidney, they are left intact. And this is an important property, especially when we're trying to go near the important structures like the collecting system where the urine is collecting. It doesn't damage that. And so it does not have the high chance of urine leaks and so on that we are worried about in tumors that are very close to the hilum. This is what the ablation zone looks like under CT. I'm not sure if you can appreciate this, but this area here, this oval shaped, is a little bit more black compared to the surrounding structures. This is the spine. This is the kidney. I'm not sure if you can see my pointer. This is the spine. This is the kidney. And this in circle is the ablation zone. It's slightly blacker compared to the normal kidney. This is the freezing that is occurring in this patient. Moving on to the heat-based systems, radio frequency and microwave. They are very similar. Their physics are slightly different. And I will not go into the details that won't bore you, but basically microwave is very similar to the microwave oven that we have at home. It uses these microwaves to cause water molecules to spin rapidly, generating a lot of heat. And it creates a big heating zone, much bigger than radiofrequency ablation. And so it's considered quite powerful. It also means that you can do the treatment much quicker. The treatment is also done using similar needles. They look quite similar to the cryoablation needles, but the properties are completely different. They are also inserted into the tumor under image guidance. The difference from cryoablation, this is a microwave ablation that's occurring, is that you cannot see the ablation zone very well. The needle is in place in the tumor, but you cannot see the actual ablation zone very well. compare that to cryoablation, where you can see the ablation zone. And I will compare these two modalities for you briefly. We use different types of needles and different settings to give us the zone of ablation to estimate that, because we cannot see the zone of ablation very clearly. After ablation, that is what the area looks like. There is more damage, charring. The area looks like it's been chata a little bit. But that's what we're trying to achieve, and it's very, very effective also compared to cryoablation. It's also done quite commonly in our institution. So comparing the hot and cold treatments, microwave ablation is much faster. You can do a treatment and complete that within 2 to 10 minutes. It is also more destructive, and that's why we need to be very, very careful near important structures. Some studies seem to suggest that the chance of the tumor coming back is lesser than microwave, but this is not proven. You usually need fewer needles because each needle is very powerful. So the cost of the treatment is really based on per treatment. And so there's also less number of hooks in the organ. The needle also kind of coagulates or fries the blood vessels, so there's less chance of bleeding theoretically. But there are disadvantages that you cannot see the actual ablation zone, and sometimes it can be a bit more painful after the treatment. Cryoablation is much slower. Typically, the treatment takes between 20 to 30 minutes. It's more gentle, as in it preserves the architecture, the scaffolding of the kidney, and therefore it can be used in difficult areas, particularly nearer the hilum, where we want to be very, very careful and not destroy the collecting system. Because it's gentle, you need more needles, and there are more pokes of the organ, and it's more costly. There's slightly higher chance of bleeding because some of the bigger vessels can remain open, but we have some techniques to overcome that. You can see the ablation zone very well, and to me that is the major advantage, because I can be very confident that the area that is being treated is not close to something important, and I'll show you that in the case example. And usually, cold itself is a very good anesthetic, so it is very minimally painful. In fact, most patients don't even report any pain or very mild, dull pain. They don't even need Panadol. What we're trying to achieve is this fried egg appearance, and this is from any kind of ablation system. You want to destroy the tumor, but also a rim of normal tissue around it. It's very important because microscopically, some of these tumors have little microscopic extensions beyond the margin. So what you can see on MRI actually may be less than what is there on pathology. When you look at it under the microscope, you may see tiny deposits a couple of millimeters outside. And that's why when we do the ablation, we always want to do a little bit more than what the kidney tumor is itself. Having said that, this area of destruction is very limited and quite small. And when you compare that with other forms of treatment, this is probably one of the least amount of normal kidney damage that we have at the moment. Overall, pros and cons of ablation. It is minimally invasive. There's no need for any cuts. The needle is about 2 millimeters. So all there is a really tiny stab wound in the skin, which heals rapidly. There's almost no scar. The recovery is quite rapid. Most of the time, patients can walk out of bed after 4 to 6 hours. They can go home the next day. Usually there's very minimal pain, and you don't even need any painkillers. It's highly effective, but there are some disadvantages. Remember that the kidney has a lot of blood flow, so there's a small chance of bleeding, which we need to monitor, and that's why you need to stay in the hospital after the treatment. There's a small chance of local recurrence, which means that the tumor can come back after ablation. Remember, the tumor is not removed, the cells are destroyed. So if 1 or 2 cells end up not being destroyed, there's a chance that the tumor can come back. And that is why we need fairly long follow-up imaging to make sure there's no recurrence. The location of the tumor and the size of the tumor is really important. Big tumors cannot be treated safely with ablation. And tumors in some locations also cannot be treated safely, and we will need to seek other forms of treatment, which other speakers will be expanding on. So as I mentioned, restricted to the smaller tumors less than 4 cm. This is an example, again, from a journal of a big tumor. This typically cannot be treated with ablation. It is classified as type 1B. There are some techniques to treat this in some places, but typically we do not recommend ablation for big tumors because they can be spread outside of the capsule or even into the bloodstream. Okay, so talking about one case, this is a patient who is a 73-year-old. This is a tumor that is in a very difficult part of the kidney. And the reason it's in a difficult part of the kidney is that it's very close to the ureter. This is where the urine comes from the kidney and goes into the bladder. Ablation in this area can potentially cause damage to the ureter. However, this patient could not be treated safely with surgery because of other medical conditions. And so we do have some techniques to treat these types of tumors as well. Tumors that are located far away, for example, here near the outer side of the kidney, these are very easy to treat with ablation. But these types that are located in the front of the kidney, near the inside, these are difficult. So what we did in this case is that we injected some air and water to separate the ureter. You can see the ureter is the structure. We put a tube inside there to warm it up. And this is the ablation zone. And we can be very confident where the ablation zone is going. If the ureter is away from the ablation zone, it is safe. And so we managed to do this treatment quite successfully and safely. And this is what the tumor looks like after ablation. One of the advantages, and the damage to the kidney is very minimal. This patient also had borderline kidney failure, and there was no change in the kidney function at all after the treatment. So just in summary, this is a picture from the old Tanjung Pagar railway station, quite close to SGH. It talks about having different modalities come together for kidney tumor treatment. The advantages of ablation are that it is minimally invasive, it's effective, there's very little pain, and very little damage to normal kidney. So even patients that have mild kidney disease, most of the time, in fact, almost all the time, there is no change in the kidney function. However, it's restricted to small tumors in favorable locations, and it needs a fairly long follow-up. How we decide treatment is through a multidisciplinary meeting. We have members of all the different specialties that are relevant come together, discuss each individual case, we talk about it, and tumors that are suitable for one method or another are then subsequently discussed with the patient, and we make a final plan for treatment. So with that, I'd like to thank you very much. I hope I didn't speak too fast, and I'm happy to take any questions. Thank you.
Hey, a very good afternoon to everybody, and thanks so much, Apurva, for the very nice talk. Thank you to all the attendees who spent your Saturday afternoon here today to come and attend our webinar. Today, I'll be talking a little bit on kidney surgery to give the surgical aspect and to share a little bit more so that you can be a little bit more knowledgeable when you're encountering these situations, or perhaps, when your friends or relatives encounter these situations, then you know who to ask to come and see the urologist. So I think both of the speakers have already given a very nice rundown on what is the kidney. I think, as members of the public are all very familiar with how important the kidney is as an organ. And I think the others have mentioned earlier that, it is the primary organ really for getting rid of the waste products of our body. Now, what's very important to know is that it has usually just one artery bringing blood with the waste products to the kidney, and then one vein bringing the very clean blood back to the body. And then these waste products will then enter the drainage system. This is basically like a longkang called the ureter. So the kidney, if you can see on this diagram here, has many little small drains, and then it goes into the large drainage system. That's the ureter, which brings the urine down to the bladder. So we have one on each side. And then when socially appropriate, we'll go to the restroom to empty the bladder, and that's how we get rid of all these waste products. So kidney cancer, why are we talking about it now? Actually, it's because the incidence of kidney cancer has really been increasing. It is currently the 7th most incident cancer, and it's actually the 8th most common cause of cancer death among men in Singapore. You can see this chart, which is gotten from the Singapore Cancer Registry from 1970 until 2021. That's like 50 years of history. You can really see that the incidence rate has gone up. And so has the mortality rate has gone up as well. So it's an important cancer, and it's affecting the kidney, which is such an important organ in our body. So how can we actually deal with it? Now, I think we've seen some nice images earlier, just to put it into context for you, oftentimes kidney cancers are now picked up at a very small level because people go for health screening or they get abdominal symptoms or pain investigated. Oftentimes the first screening scan you get will be an ultrasound scan. Earlier on, there was a very nice question in the Q&A which asked, do these ultrasound scan or perhaps CT scan, do they damage the kidney? Now, ultrasound scan is a very safe scan. There's usually no additional medication given. There's also no radiation. So I think it's a very good scan for initial diagnosis of any kidney problems. In fact, in our clinic, we often have an ultrasound machine right next to us so that we can use it to scan patients. But definitely, if you're worried about kidney cancer, we often get our radiology colleagues to do a very thorough scan for you. But the definitive scan, which is to actually see in detail, is really the CT scan. And sometimes we need to give a contrast agent, which is actually a dye, so that the CT can be seen more clearly. And that can sometimes be damaging to the kidneys if you already have kidney problems. So it's important for us to evaluate your kidney function before we get you to do a CT scan. Then we can know whether or not to give you the contrasted study. Now, it's important for us to do these scans really to help us look more into how extensive, if you have a kidney cancer, how extensive is it? And, very commonly, we hear on TV or, we see in the movies about people diagnosed with stage 4 cancer. So in everyone's mind, it's always, which stage of cancer do I have? What stage is it? And this is a very simple schema. Essentially, the stage tells you how extensive the cancer is. So the higher the stage, the more extensive the cancer. Stage 1 and 2 cancers are usually confined to the kidney, whereas stage 3 or stage 4 cancers have gone outside the kidney. And in stage 4, it's usually invaded other organs. So as you can imagine, if those with a higher stage kidney cancer will require more extensive surgery. Whereas if you are only in stage 1 or stage 2, perhaps a more limited surgery can solve the problem. Or perhaps we can even consider ablation, like what Prof. Apurva mentioned earlier. So let's go to a case study just to make it a little bit more real. This is a lady who saw me in 2018. And this is the kidney, the CT scan that I was telling you about. This was a contrasted CT scan. So the one on the left really is the front view of a cross section. So we can see a little bit of the left kidney. They're in a different plane, so you can't see the whole thing, but you can see the right kidney here. And there's this lump that's right at the bottom of the right kidney. And that one is marked with that yellow line is about 33 millimeters, which is about 3.3 cm. And then we have the cross-sectional view on the right-hand side, where you can see that that same lump there in the cross-sectional view is also measuring about 3.3 centimeters. So what should we do for this patient? And, she was offered to have the kidney removed by another surgeon, and she actually came for a second opinion to see, can we do something more limited, less extensive? I'll go on now to tell you a little bit about what are the treatment options for a kidney tumor like this. So I think the first question that the treating urologist often needs to answer is, do we actually need to treat your tumor? Like, is this something that's going to be dangerous to you? Now, this often can seem counterintuitive. You say, hey, there's a lump, why don't we get it removed? Important organ. And even if you remove just part of it, you're actually taking on a risk. There's a risk with being given to that kidney, that it may be damaged or it may have to be completely removed, for example, and that might impact your kidney function overall. And of course, we need our kidneys to continue functioning for the rest of our lives. Active surveillance is what we call active monitoring of incidental renal masses. The reason is that of renal masses less than 4 cm, we actually find that about a third of them are actually benign. They're actually not cancerous. And there are also some metrics that look at how fast do malignant or cancerous tumors grow. And it's been found that they typically have a growth rate of about greater than 3 millimeters per year. So that's the reason for monitoring. Perhaps using active surveillance to monitor, we can actually find out which are the more dangerous tumors by looking at their growth rate. And long-term follow-up of stable or less than 3 centimeter kidney tumors have actually shown a very low rate of cancer spread, which is about 3%. And active surveillance could thus allow us to treat or remove only those tumors that prove to be aggressive by growing. What's the standard treatment for kidney cancer? Now, the standard treatment is what we call a radical nephrectomy, removal of the entire kidney. And you can imagine if you have cancer and you remove the entire kidney on that side, that's done. We've already resolved the problem. There's no question of will the cancer appear again in other parts of the kidney or problems like that. So this is an image of, for example, something with a stage 3 cancer, which I deal with as well. Sometimes in these cases, there's really no choice but to remove the entire kidney because, as you can see, the tumor has occupied the entire kidney already. In fact, it's extending into this vein, the main vein of the body. We call it the vena cava. It's basically a big highway for all the blood to return from the legs to the rest of the body. And, you know, in this case, we have to remove the entire kidney to get rid of the tumor, and we actually have to pull out this part that's in the vena cava and repair it up again. So in this case, there's actually not much choice. But in a smaller tumor, similar to, you know, the case that I showed, the question is, can we just remove one part of the kidney? And thus we preserve the rest of the kidney in order to, you know, maintain that function. So instead of having to lose one kidney, you know, perhaps we can have 1.5 or 1 2/3 kidneys, just removing that lump. And this cartoon actually shows, you know, how we would go about doing that. And this is where it's important. As I told you, as I shared with you earlier, the kidney only has one artery going in and one vein coming out. So really, you know, it's like a cul-de-sac. So what we do is we actually put clamps on these vessels and stop the blood flow so that temporarily we can quickly remove this tumor, because the kidney is like a sponge. It contains a lot of blood. The blood of the entire body has to flow through the kidney to get filtered. And, you know, that can cause tremendous bleeding. So we put a clamp on those vessels, then we remove the tumor, we quickly stitch it up, and then we unclamp it. And there's a minimal time frame for us to do this. We can't leave the kidney unclamped, ideally for not more than 30 minutes. So in 30 minutes, we have to remove the tumor and repair the kidney, you know, very accurately. So that's where the challenge of removing just one part of the kidney is. We actually need to, you know, do this in a very careful and a very diligent way in order to be safe, be successful in removing the tumor, and also, you know, by allowing the kidney, the rest of the kidney to survive, so we do not cause ischemia for too long a time. So I'm going to show you a video now, which is about how we do it today, which is using a robot to actually do this so that we can do our surgery with high accuracy. So I'm going to show you this 2-minute video. And after that, I'll continue.
You have been diagnosed with kidney cancer or a benign tumor or cyst on your kidney. Your doctor recommends that you have a robot-assisted partial removal of your kidney, also known as a partial nephrectomy or RAPN. This animation shows how the procedure is done. The goal is to remove the entire tumor while sparing blood vessels and healthy tissue. RAPN is performed under general anesthesia. You will lay on your side on the operating table. During a general anesthetic, medications are used so you do not feel any pain during the surgery. When you are fully sedated, 3 to 5 small cuts a few centimeters wide are made in your belly. Surgical tools and a tiny camera are then inserted through these cuts. The surgical tools are attached to the arms of a robot, which are controlled by the surgeon through a console placed next to the operating table. It is important to understand the robot is not performing the surgery. Your surgeon will perform the surgery, but the robot console allows for more controlled and precise movements. Carbon dioxide gas is used to inflate your abdomen to create a bigger working space for the surgery. With the use of diagnostic scans taken prior to the surgery, the surgeon looks for the tumor in your kidney. When needed, the surgeon will clamp the kidney's artery to stop the blood flow to the kidney and the tumor. This reduces the bleeding when the tumor is removed. The surgeon then separates the tumor from the kidney. Once the tumor is removed, the kidney must be sutured together tightly before the blood flow is restored. The tumor is put into a plastic bag and removed through one of the cuts. The surgical tools are removed and the cuts are closed. You may experience some shoulder pain for 1 to 2 days due to the carbon dioxide gas used to inflate your abdomen. After the operation, it is important to take pain medication, drink, eat, and breathe well. You will be monitored for some time after the operation to see if the tumor comes back. Most of your kidney function will recover within some months after the operation. Ask your doctor what follow-up will be like and who to contact if you have any concerns. RAPN is performed by experienced and trained surgeons. As with any surgery, complications.
Okay, I'm just going to stop there for a minute and just to share that So this is how we do robotic surgery, essentially doing the same removal of the kidney tumor, but using a robot to assist us. And this video was produced by the European Association of Urology for patients, and I thought it was a very good description and a visual sharing to help all of you guys understand a little bit better. Of course, there are many different types of surgical robots, but definitely we use a lot of surgical robots to do these procedures. But occasionally we still do an open surgery in some very specific circumstances. So that really depends on the specific case of that patient. So a little bit about follow-up after robotic partial nephrectomy. There's removing the part of the kidney. Actually, whether it's done robotic or even whether ablation is done, what's important is that it's a patient journey. So we continue to journey with the patient. It's not that the surgery or treatment is done and then we can forget about it. Oftentimes in cancer, there's a very big concern about recurrences and can they occur. So what we do is we assess the patients clinically, look at the tumor pathology, and then we decide what is the risk of recurrence. So we classify typically the risk of recurrence into low, intermediate, or high, and then there will be a different schedule. For those with a higher risk of recurrence, you need to do more frequent CT scans. But as I did share, CT scans expose you to radiation. So if we can avoid it, we don't want to do it too frequently also. And that's why for those with a low risk of recurrence, they have a more infrequent CT scan schedule. And once they're past the 3-year mark, oftentimes less CT scans need to be done. In fact, if you have a low risk of recurrence after 5 years, often we do not need to scan you anymore. So your doctor will really decide on this kind of schedule for you after your treatment. So just to go back a little bit to our case study, this was the tumor that I showed you in this patient who saw me in 2018. And she went for robotic removal of this tumor because in this position, that was a good procedure for her. Again, we went through a multidisciplinary discussion with our interventional radiologists, with our radiologist colleagues to decide which is the best treatment, like we do for many of our cases. And this is the follow-up, which was CT scan, which was done last year. So that was 4 years out. She's reaching a 5-year mark already. You can see that right kidney there looks almost normal now. There's no more mass below, and most of that kidney seems to be functioning well. On the right-hand side, you can see a little bit of white, bright sparks there. Those are actually let me see whether I can get my pointer out and show it to you. They are actually over the bottom of the kidney, and those are the sutures that we put in. So some of them are still retained there. And that kind of also tells us where to look at if we are looking for recurrence. So the benefits of doing a robotic partial surgery is that you get a precision of an open surgery, but you get a minimally invasiveness of a keyhole approach. Usually because it's minimally invasive, you get a 1 to 2 night stay. There's complete excision of the tumor, which is good in terms of cancer control, and we get to retain the kidney function. Of course, the risks are that one has to be able to undergo anesthesia. It's a 3-hour operation, 2.5 to 3 hours, so you'll be under anesthesia for that time. With any partial removal of the kidney, remember I showed all those drainage systems in the kidney and those blood vessels, so there's a risk of urine leak or bleeding from there. If these things happen, it means that the stay in hospital may have to be longer, or some additional procedures have to be done to help the kidney survive better and resolve these leakages. There's also a small risk of tumor recurrence, of course, in the other parts of the kidney, which is why it's important to do your follow-up scans and come for follow-up. So it really is a journey, like I shared. If the cancer recurs in the kidney after partial removal, sometimes, occasionally, another partial surgery or ablation may be needed. Or if the recurrence is extensive, then total removal of that kidney may in fact be needed. Because at the end of the day, the most important thing is cancer control. If there's any recurrence, we want to know early so that we can do any other interventions if required. So to summarize, I think kidney cancer is actually a very treatable disease nowadays. No matter what is the stage, there are many different treatment options. Small cancers can potentially be cured while sparing the rest of the kidney through surgical removal or ablation. And of course, treatment selection depends on the location and extent of the tumor. So I thank you very much for your time this afternoon. I'm going to hand over next to a very good friend and mentor, Prof. Henry Ho, and he's also brought his patient, Ms. Lindbergh. I think they're going to have an excellent sharing session with you to share with you about a patient's journey. So without further ado, Henry, please, and Ms. Lindbergh, I'm going to hand it to you.
Thanks, K-Jack. Yeah, it's really wonderful. We learned so much together. And I really want to start off by thanking immediately to Ms. Lindbergh Lim for the opportunity to have this very special session for this public webinar. I think we have heard many things, to learn many things, but I think nothing beats the fact that we have Lindbergh today to share with us exactly what was her journey as she goes through as a patient, individual with kidney cancer. I think, first of all, maybe I just do a self-introduction of myself. I'm a senior consultant urologist in the Department of Urology in SGH. I'm also the chairman of surgery at the same time. So maybe I'll pass the time over to Lindbergh to do a little bit of an introduction of herself and what she does, and also what she likes to do in the free time. Lindbergh, well, over to you.
Hi, good afternoon, everyone. Good afternoon, Prof. Maybe I start by introducing myself. My name is Lindbergh, 58 years old, mother of 2 boys. Currently, I'm still working for a medical device company that is dealing with diabetes management as well as drug dispensing system. So the first thing that maybe I want to talk about is how my cancer is being diagnosed. Okay, so sometime in February 21st, 2021, if everybody still remember, that was the peak of COVID-19 and we are all under lockdown. So I have decided that, instead of staying at home, I still have to maintain my health because I'm a cardiac patient and currently being under the care of NUH. So I thought that maybe I organize maybe a weekly walk, and we decided on maybe every Sunday we will gather in a PCN or maybe in Chinatown or in Little India. So we will go around the whole area, okay, and spend probably about 2 hours in the morning. We start at about 7, and then we will cover about 10 kilometers of walk. Okay, so this particular Sunday, as usual, we decided to go around Chinatown. Okay, and Chinatown is very interesting because there are many temples there. But because of the lockdown, we couldn't go into the temple. So we just pray outside, okay? And after the walk, we arrived at Bio Crescent Market around 10:30. And after the walk, we are all very hungry. So as usual, Singaporean, we will look for good food, okay? And we decided to sit down and take a rest and take some food there. But when I sat down, suddenly I felt very giddy, okay? And that made me collapse and I lost consciousness. So my husband was pretty alert because I'm a cardiac patient, so there's always a chance that I'm having a heart attack. So he decided to call an ambulance. Okay, and I'm lucky because Bio Crescent, the nearest hospital is actually SGH. Okay, and the ambulance was actually deployed within 5 minutes, and I was sent to the A&E. Okay, and when I was in the A&E, I think there was some sort of like a protocol that they have to do a chest X-ray. Okay, and from the X-ray result, they found a dark patch near my heart. So the A&E department decided to ward me, and then they scheduled a CT scan on the next day. Okay, so on the next day, in the morning, I was sent to the CT for a CT scan. Okay, and this time around, when the CT scan was out, they found a dark patch near my heart. And then the radiologist also picked up another dark mass at the bottom of the scan. Okay, and they do not know what is it. So they decided to conduct a second CT scan on the next day. Okay. And the second CT, when it was done, I was sent back to the ward. Okay, and immediately I noticed something is wrong because after the first CT, I was told to drink lots of water to clear out the contrast from my body. But the second CT, on the other hand, nobody gave me instruction that I had to drink water. Okay, so I knew that something is really wrong. Okay, and the ward doctor came to visit me, as well as another doctor from urology department. Came to the ward, spoke to me. I looked at their faces and I know that I'm in deep trouble, okay, because they told me I had stage 4 kidney cancer, okay, and at that point, I really do not know what is stage 4, right? Because to me, stage 4 is quite close, like to a terminal cancer type of situation, okay. And the doctor actually asked me, do you have any symptoms like blood in the urine? Do you feel pain? Do you lose weight? And I was like in a shock because there wasn't any symptom at all. Okay, and how is it possible that there's a 8.9 cm tumor mass in my body and I do not know about it? Okay, and I told the doctor how I wish I can slim down, right? Lost some weight because my cardiac doctor is always complaining that, I have to lose some weight, okay? And how can I be walking 10 to 12 kilometers on a weekly basis if I feel pain, right? So that is actually quite shocking, right? Because there is basically no symptom. And at that point, I was really very angry because to me, I was at the peak of my health, right? Because I persist on the walking and actually my stamina is really good, right? So when this was disclosed to me, I was really, really very shocked. Yeah. And guess what? My family members, my boys, when they heard about this, all of them were shocked, okay, especially the 2 boys. They couldn't believe that their mom is actually having a stage 4 cancer. So in a ward, I requested for the earliest appointment with Prof. Henry Ho of Urology Department. And then on the ward bed, actually I was frantically looking at my mobile phone, going through all the information in the internet and YouTube regarding kidney cancer as well as renal cell carcinoma. I just want to find more information because I was really, really very scared. Okay.
Yeah. Limbert, maybe before you go on even further, can you share with the audience that, what was, the scans, you did 2 scans, right? The CT scan, and how was the experience like? Some people are very afraid of doing a CT scan, Could you tell us, because you also mentioned a little bit about the contrast, could you explain to the audience what do you mean by the contrast and also the CT scan? What was the environment like? Yeah.
Well, the CT scanner is actually located in the, I think, diagnostic radiology department, and it's actually in a room. So when you enter the room, you see a big machine, which looks like a gantry, right? So you lie on the bed, and I guess the bed is will move into the gantry, and then the radiologist will give very clear instruction to you what you're supposed to do, okay? And before you actually, there's a preparation that you have to go through. They will put a plug on you where they are going to inject the contrast in the middle of the scan, okay? So I guess when you go into the machine, I have to tell myself to relax because some people really will be quite scared when you go into a closed gantry system and you do hear noises and you can feel the X-ray tube going round because it's actually a helical CT, right? So they actually do slices of scanning. So you can hear spinning sound, okay? But I guess the best thing the patient could do is just to relax, okay, and listen carefully to the instruction coming from the radiologist or the radiographer telling you to breathe in and breathe out. And when they ask you to hold your breath, you try your best to hold. Okay, so the whole scan is pretty fast. Okay, and in the middle of the scan, they will inject the contrast into your vessel, and then at that point you will feel some sort of like heat going through your body. Okay, and that sensation is not too bad. Okay, the whole thing is that you just have to relax and cooperate with the radiologists. Okay, yeah. So that was my experience. The whole thing can be completed pretty fast, within 15 minutes or so.
So actually, just to also add on to what Libert's description for someone who's gone for a CT scan, there's also the ultrasound scan, which is the one that, you know, most ladies who give birth have a bit of gel for their baby scans. That's the ultrasound scan. So the one usually we do not give any contrast. I think there's also a question on the chat. I thought maybe I just answer at the same time. The scan sometimes with the kidney is a bit weaker. It may weaken the kidney temporarily, but for a normal individual, there is actually no impact from the contrast. Then you may ask, why do we need to put a contrast? It's really just to make sure that we know whether the tumor is alive or not, whether is it, is any dangerous parts of the tumor itself. That's why the contrast is the purpose of doing that. So it's crucial for us to do the so-called the contrast. As for the CT, the risk of radiation is low, and therefore I think compared to X-ray, of course, much lower, but it's a very necessary step for us to make the diagnosis of the cancer. And then, of course, eventually what else needs to be done. So, Libert, maybe we move on a little bit away from your scans area. And how did you feel and what are your worries when you first heard about the diagnosis? Ms. Zhang, you mentioned a bit about being angry. You were very healthy and fit. What are the things that you're worried about that if you have to do something to your kidneys, what are the areas of your life you're worried about? Yeah, in that moment.
Well, I think the very interesting thing was that, I was discharged from the SGH by actually the cardiologist. Okay, and they told me that the reason that I have fainted was because the beta blocker that I'm taking is too high. And that's the reason why the blood couldn't reach my head. And then when I stopped walking, the blood pulled at my leg and couldn't get up to my head. That's why I had fainted, right? So the cardiologist lowered the dosage of the beta blocker by half, okay? And the dark mass that they found in the first CT is actually a foregut duplication, meaning that it's like an esophagus that wasn't properly formed. I have two esophagus during my fetal state. One become a functional organ, the other one just remain to be there, okay? So this diagnosis of kidney cancer was an incidental finding, okay? So that's what a couple of the speakers talk about incidental findings. Mine is actually through incidental finding, okay? And of course, when somebody tell you have cancer, that is really very bad news, right? So the first thing that comes to my mind is, am I going to die, right? If so, how long do I have? And then what should I prepare, right? How do I communicate with my children? How do I communicate with my spouse so that, everybody will be ready for the worst, right? So I actually went through the 5 stages of grief. Okay, and everybody knows, right? First is denial. Why me? Why of all the people, why me, right? Because I thought that I'm healthy, right? But turned out to be terrible, right? Second thing I have gone through is anger. Felt very angry, right? Of course, the third thing is bargaining. I kept telling myself, what if this, what if that? I start bargaining. Can it be true? Can it be, lots of questions in my mind. And then, of course, you go into a depression state. You feel very depressed. Yeah. Okay, of course, when you come to the 5th stage, that will be the acceptance stage. right?
Yeah.
So once you accept, you tend to calm down a bit, okay? And then I discussed with my husband the next course of action. What are we going to do, right? So the first thing I did was I seek consultation with another hospital. I just want to hear from another hospital what will be their view on my CT scan. Okay, then because my mind is like very messy, I decided to write down all the questions in preparation for my consultation with you, Prof. Ho. Okay, and I thought that by writing down, I have my thought process being more organized, and it will be more productive when I see you.
Yeah.
Okay, so, and then of course, because I'm in the medical industry, I tend to read up and understand as much as possible.
Yeah.
What are we talking about? What is kidney cancer? What is the survival rate? Survival rate is very important to me, because if I want to have a strength to face it, I want to make sure that I have a chance to survive. If not, why bother, correct? So this is a question. I will zoom in on survival rate. And then
Maybe we can actually show you. You don't mind? We can show your scan if it's okay, Limber.
Sure. Go ahead.
Yeah. Maybe that helps to so this is a normal kidney, just for a reference for many people who may not know the shape. You can see the red patch is we intentionally draw it for you. To see a normal kidney is about 10 cm in length. And next slide, there's a normal kidney. And the next one is actually a Limburg scan. Here you can see the tumor is intentionally drawn for you. Here in yellow, I annotate it for it. Can see it's fairly big. I think Lindbergh also mentioned it's about 9 cm, 8.9 cm at the time. And that really occupies like a lot of the kidney itself. And I think she also mentioned a little bit about it being stage 4. I think it was actually because it was actually very stage 4. That means in most clinical stage 4 means it has spread. But for what the Lindbergh has described was because it was very close to the pancreas. And we thought from the scan that it was actually attacking the pancreas at the same time. So that was why she mentioned stage 4. But in truth of the matter, I think for her, we will decide discussing that we will probably need to remove the tumor and also maybe even part of the pancreas. So those are very difficult days, right? Remember? And that's why Lindbergh gave a very good tip just now, that if we are all very confused with the diagnosis of cancer, sometimes it's good to write down some of the questions, and that would really help to crystallize some of the conversation you have with your doctor, what your worries are. And I think all of us in the medical industry are very happy to answer all your questions one by one. I think your concern and our concerns are different, but we want to respect your concern. And you might always tell every of my patient, there's no stupid question. We're here to make sure we're all on the same page. So maybe the next slide, go down, you can actually go and see after the surgery. Brenda, would you like to go down the slide, please? Yeah. And this is after the surgery. You can still see the kidney is still there and the tumor is clearly been removed, and we are able to preserve nearly 70% of Lindbergh's kidney. I think this is what we did for her. Maybe Lindbergh, can you share with us a little bit about, your thought process when we have to tell you that you have to remove part of your kidney and versus that removal of the whole kidney? What was your struggle? Maybe I'm sure it's your question in your list that you gave me the time.
As I said, the first appointment with you, Prof. Ho, that was I'm actually under great anxiety. Most of the things actually, when you are talking to me, I couldn't really register. I just couldn't understand what you're talking about. Okay, but roughly, I think that Prof. Ho, you propose that because of the size being so big, radical nephrectomy should be the way to go. Okay, and that is by open surgery and of about 12 cm incision, right?
That's right.
And then, of course, the other way is partial nephrectomy, which is possible if the cancer did not touch the other organs like the pancreas or the spleen. Okay, and for this, I think there will be about 5 holes, 5 cuts, And then the biggest, the largest cut is actually 7 cm. Okay. And as a lady, okay, I am actually quite disturbed that suddenly I have to have so many holes on my abdomen region, right? It looks very ugly. Okay. But I also understand that, you know, for cancer, you want to clean it up as much as possible. You have to clear all the cancer cells. So I actually expressed my wish to you, Prof, that I want to save my kidney as much as possible. Because the rationale that go through my mind is that if I have only one kidney, will it be less efficient than having 2 kidneys? Okay, and thus 1 kidney actually means that, you know, I have a higher chance that at the later stage of my life, I have to go through dialysis. Okay, and the other thing that, you know, that actually bothers me, and I was really disturbed, is that, you know, I realized that, you know, how many of my organs will be removed. We're talking about the spleen, we're talking about the pancreas. It's like going through the biggest joke of your life, and you're actually feeling perfectly all right. No pain, nothing, right? And can you really understand that I have to go through revise all the anatomy, understand what the functions of these organs and the implications that if they are removed, what is going to happen to me, right? How is my life going to be affected without all these organs?
Yep.
So after the appointment, my head was really spinning and in a blank. And I think that Prof Ho, you saw me sitting in the waiting area, and you came over and sat beside me, and you actually assure me that if I have any questions, I can actually write to you, which is actually very, very special to me, because I think that, you know, it shows that you really care about me. Okay, and you also offered that, you know, there will be another session with the whole family, so you could discuss the treatment plan and answer all the questions by my spouse and my boys. And I was really, really appreciative. I think that was a very kind gesture. And immediately I knew that you are a doctor who cares. And that is a very, very special quality. So if you ask me about, as a patient, how do I assess, okay, whether I will go through the surgery with SGH or another hospital, is very much determined by the doctor that is taking care of me.
So actually, it's not just me, Lindbergh. I think my entire hospital, my teams are all the same. Every single doctor in SGH, we practice the same way. It's just not me. So we're all very happy to communicate with you as much as possible. Lindbergh, just quickly go back to now that you are so many months after the operation. So how are you back to normal? And any take-home messages for the audience that you would like them to walk off from this session with? Yeah.
Well, I think that, you know, of course, you know, going through this experience is actually quite a big trauma for me, right? But after the surgery, I think that, you know, I know that I have to look at my lifestyle. Not just the physical lifestyle, you know, keep fit and things like that. But I think the mental health part is very important for me, right? So I watch my diet. I eat healthily as much as possible, avoid processed food, okay, and I know I need to lose weight, okay, and I basically push myself to do sports, right? And I started jogging, cycling, and I told myself not to have any fear, because once you have any fear of doing anything, you will not take the first step, okay? So I actually jog about 3 kilometers to 4 kilometers on a daily basis now. I lost quite a bit of weight, okay? And I know that, you know, to do sports, don't be too competitive. Focus on the breathing, the posture, and take it slowly. And of course, you have to find motivation why you are doing the sports. Okay, so for my case is I want to go mountain hopping in Korea and Japan. And sometime in Korea, one day we cover 2-3 mountains. Yep. Okay, so I know I have to keep fit. Okay, and then of course mental health. for cancer patient, no matter what, keep away from stress. Watch out for anxieties. Okay, and then find things, hobbies that will relax you. Okay, and for my case, I found it in music. I started playing piano again. And another very important thing, you got to have very good support coming from family. If you feel stress, you feel anxiety, you have to talk about it. You cannot bottle everything. And when you notice, you have to very consciously notice whether anxiety is building up in you. And when you have anxieties, take deep breath. It helps, and it helps you to go to sleep. Okay. And I think lastly, to talk about surveillance and things like that, to prevent remission and things like that. Work very closely with the care team. Okay. If you have any questions, anything that bothers you, have to open up, talk to the doctor, talk to the care team. Okay. Yeah, I think then the journey of going through the cancer will be an easier one. Okay. And I truly believe that it's not the skill that is the most important coming from the doctor. It's actually the caring hearts and the compassion that motivates the cancer patients. So I felt,
yeah, thanks, Limbert. Yeah, I really appreciate this very much. We are all very honored to be able to care for you. So I think we will have run out of time. So I'll stop here, Limbert. Really appreciate this opportunity, and we are very honored. I think the audiences are very honored and very happy that they're able to hear it from you firsthand, your journey, your treatment options, and all this. So really very thankful for you to do that. Not many people can do that. I'll pass the time over back, but answer some of the questions that we may not have done. So thanks, Kenneth.
Yeah, thanks, Prof. and Limbert. That was a fantastic sharing session. And I'm sure everyone benefited from just understanding the patient journey as well. So I think we'll take this last few minutes to quickly catch up with some Q&A that we have. Maybe I'll start the ball rolling. We have a question on what's the cause of kidney cancer, and why is there an increase in stats? Any prevention? So maybe at this point in time, I will share a slide of mine. Sorry. Yeah, I kind of anticipated this question to come. So just want to direct everyone to another resource on this topic. I've actually done a Q&A covering some of these questions, and it's actually hosted on SGH website as well. The link is provided below, but essentially, there's quite little we can do with regards to prevention of kidney cancer. We know the risk factors such as smoking, obesity, high blood pressure, but then again, when we call them risk factors, the extent of how much they play in actually developing the kidney cancer is, I would say, quite low. But in any case, at the end of the day, it doesn't harm any of us to live a healthy lifestyle. Stopping smoking, watching obesity, and controlling high blood pressure, these go far beyond the benefits of prevention of cancer, but more also in terms of our cardiovascular health. But these are some of the things that if you are considering. There's a whole large part of risk factors that are not within our control, such as genetic syndromes and family history of kidney cancer. So, yeah, just going back. So there's no way to prevent kidney cancer. I just want to wrap this point up quickly. Healthy lifestyle, avoid obesity, control high blood pressure, smoking. Some of these risk factors not within our control are like people who are on dialysis. They actually, by virtue of being on dialysis for kidney failure, they actually stand a far greater risk of developing kidney cancer down the road compared to the general population. And of course, in terms of family history, we know that there is evidence to suggest that family history plays a role. And if I can stop share now and maybe move on to the next question that is on the same topic. Oh, sorry. Yeah. Anyway, so basically, relative, the mother had kidney cancer. What are your chances? So there's some data to say that you stand 4 times the risk of developing kidney cancer yourself. But this is just a general guideline. There is no hard and fast rule. There isn't a specific number that we can put to it. But generally speaking, yes, there is a slightly higher risk for the individual with a first degree relative with kidney cancer. I'll quickly move on to this second question. I'm a lupus patient currently under a rheumatologist, Prof. Fong at SGH, visible blood urine since 2004. Now, so this brings me back to one of my points. Remember the blood leaking out of the kidney versus blood actually bleeding along the urinary tract. So, and I also mentioned that rheumatology, there are many rheumatological conditions that actually affect the state of the kidney. And so lupus is actually a well-known one, a well-known condition that can actually affect the blood vessels of the kidneys, not just in the kidney, but elsewhere in the body as well. And this can give rise to, macroscopic or visible blood in the urine. But nonetheless, usually we will still go through a full thorough assessment to ensure we don't miss anything that is reversible and treatable, like stones, infection, or as well as cancer. So as long as these surgical conditions are excluded and we're fairly sure that this is due to a medical underlying problem, then it boils down to just controlling and mitigating the side effects of the medical condition. Yeah. Okay, I think we have a couple other live questions to be answered. I will hand it over to Jack. Maybe.
Hi, thanks. Yeah, so I think that there were 2 questions. One is, are there symptoms for kidney tumor? And the other one was for survival of stage 3 kidney cancers. I thought I would answer both questions because they are kind of related. Now, the symptoms for kidney cancer really depends on the stage at which it presents. So if it's early cancer, like at stage 1 or stage 2, sometimes there are no symptoms at all. And many of these cancers are discovered incidentally, for example, from health screening or something, or those people who have a family history of kidney cancer, for example, they are more particular, they are scanning their kidneys more regularly, and those get picked up. When the kidney cancer is more advanced, like stage 3 or stage 4, they can sometimes present with pain in the back or in the abdomen and blood in the urine, for example. It can also sometimes present with a bit of fever that doesn't go down. So sometimes a combination of these symptoms, warrant the investigation to the kidney. And there's a little bit about recurrence rate. So of course, the recurrence rate depends on the extent of the cancer as well. For example, stage 1 and stage 2 cancers after being operated, stage 1 has a recurrence rate of less than 5%. Whereas if you have a stage 2 kidney cancer, maybe it's about 10%. If a stage 3, maybe it's something about 30 to 40% risk of recurrence. Even if the cancer is surgically removed, they're more extensive. There are likelihood that there are already some cells of the cancer that are already circulating and have gone to the rest of the body. They may have seeded somewhere else already. So patients often ask, we did the staging scans, we scanned the lungs and the rest of the body, and it was negative. And, we had the tumor removed already, so why do I still recur? So I often tell them, by the time a scan can really pick up a lump, there are already tens of thousands of cells there. So if you have a situation where you have circulating cells or even small tumor deposits, those are not currently detectable using today's technology. So that's the reason why cancers sometimes can recur. So we do have a few ways that we get around this. Firstly, those with high stage cancers, they need to be monitored more carefully. And then, for some with high stage kidney cancer, some of them go on to what we call adjuvant treatments, like they are helping treatments, for example, some kind of immunotherapy or targeted therapy, the oral medication kind of thing, so that we can reduce the risk of it coming back. So there are some of these measures, and I hope that kind of answers the question on why is it that tumors can recur even though they are surgically removed. Thanks so much.
Hi everyone. I thought I'd answer a couple of questions related to imaging, so I thought I would answer those. Ultrasound is usually the first type of imaging that is done for kidneys because it is very safe, as Prof. Henry mentioned. There's no radiation, there's no need to inject anything into the body. In fact, it's so safe that it's done in pregnancy because we know that there are no harmful effects on even the developing fetus who is very sensitive to radiation. So ultrasound nowadays, because of a lot of developments and in technology, it's very precise. It can tell us down to very, very small details, less than 1 millimeter. You can see the structures very clearly, but it's affected by how deep the structure is, how deep the organ is. The closer it is to the skin, the better we can see it. The deeper it is away from the skin, the harder it is to see it. And some structures are very difficult to see on ultrasound. For example, bones. Bones reflect sound. So what ultrasound is you send sound waves into the body and you detect the echo of this sound. So some structures are not good for ultrasound, but the kidney itself is actually very, very good. We can see the whole organ very clearly. We can see the blood flow into the kidney. We can see whether there's a blockage of the kidney, which causes ballooning up of the collecting system called hydronephrosis. We can also see some stones. And certainly for tumors, we can see a change in the outline of the kidney. We can see a structure within the kidney that is different from the surrounding normal structure of the kidney. Sometimes the blood flow to that area is different. So there are many features about the mass that can tell us whether or not it is suspicious. And in those cases that we worry about tumor, we will then go on to other forms of investigation like MRI or CT. And sometimes we may need to recommend a biopsy where we put a needle into the mass and take a piece of it to look under the microscope. So in summary, ultrasound is the first investigation that's done. It's very accurate and it's very sensitive, but it may not be enough on its own to make the final diagnosis. Thank you.
I think we have come to the end of this webinar. I once again want to thank everyone for staying throughout and very good questions shared and asked. I hope everyone benefited from this webinar. Thank you once again to all the speakers today, especially Ms. Lambert Lim for sharing on a very intimate detail her patient journey as well. So thank you, and I wish everyone a very good weekend ahead.